last year or attended virtually, you recall that we had an afternoon session that was called Connecting the Dots, housing and healthcare. And, for those of us who go out and, take care of people on the streets and in campus, of course, the most glaring thing is that they're unsheltered and unhoused. And for God's sake, it's like the weather is bad. There's water everywhere. Sanitation is almost non-existent. And then we go and say, well, what kind of medical issues do you have? Well, let me tell you what kind of medical issues. First of all, I need to be in the housing. I need to be somewhere where I can actually concentrate on myself instead of worrying about the snakes, or the rats. So that connection, I think, is really important. And, a lot of people say that housing is healthcare. And, in any kind of a healthcare symposium that we have, we cannot forget about housing. At the core of it, this is what we really need. Every human being is entitled to live in a place where they feel secure. So last year we had a wonderful panel discussion with many of our leaders, local leaders, both from the city and the county, to talk about the interface essentially between housing and healthcare. And so we were really fortunate to have many of the panelists from last year to come back and maybe give us an update on where they are in their type of work that they do, what part of their work actually addresses the housing and healthcare issue, and also what's on their wish list. What is their vision in the position that they hold. So the format's going to be we have 4 wonderful panelists here. All from local organizations, and we're going to allow 10 minutes or so for each one to come to the podium and kind of describe what they do and how their work actually affects housing and healthcare. And then after each one has had a chance to go through their kind of a solo presentation, then we're going to open it up to questions from the audience, and we're going to be able to go until 3 o'clock or maybe a little bit before then. So hopefully we'll have plenty of time for great discussion. So I'm going to first introduce all 4, and then we'll get started with the individual presentations. The first one on my far left is Kannika Cunningham. Dr. Cunningham serves as the Director of Public Health of St. Louis County, where she brings a deep commitment to advancing health equity and supporting under-resourced communities. She's been very, very busy, very busy. I can tell you that I just heard her on NPR, just the news just last day or so, whether it has to do with immunizations or anything else that's going on in our county and our region. Kannika is definitely in the forefront of that. And Kannika, thank you again for coming today. Next is Derrick Melton. Mr. Melton is the St. Louis County Chief Executive Officer for the Federally Qualified Health Center, FQHC. Derrick was here last year as well. Great presentation, great discussion, and we asked him to come back and give us an update. And Derrick, thank you so much for joining us again this year. Next, we have Adam Pearson. Adam is a St. Louis native and the Director of the Department of Human Services for the City of St. Louis. Adam's been also quite busy. We did have this natural disaster. It was the last May, I believe, a tornado that I had never seen the power of a tornado like I did this one that came through our town, and we're still trying to recover from that. And Adam has been very busy, very instrumental to trying to get us back on the right track again. Again, thank you for taking the time from your busy schedule, Adam, and thank you for coming today. And then last but not the least is Dr. Nolan. For those of you who were here earlier, I gave an intro. He is the founder of StreetMed STL. He started the whole program back in 2020 and just a single backpack during the COVID times. And because of leadership, now we have StreetMed STL with many volunteers and trying to basically do the right thing for people who you just saw. on the streets as well as in encampments. So thank you, Nathan, for moderating, and thank you for being here. So, Kannika, I'm going to maybe start with you if you want to just come to the podium and.
There we go. Okay. All right. Can you hear me? So I will not take 10 minutes, but thank you all for being here today, but then also for allowing me the opportunity to speak and represent St. Louis County. So in St. Louis County, there are a few things that we are doing to address homelessness in the county. There's one last point I want to speak to, and I'll probably bring this up multiple times. I think I had my reality check last year when it comes to how policy decisions and policymakers on the local level can impact the work that we do. But on a high level, the health department, in collaboration with St. Louis City Health Department, we put out a 5-year plan called our Community Health Improvement Plan. One of the sectors on there is for both departments to focus on the intersection of health and economic mobility. So what that means is, as a health department, we understand that being unhoused, not having a job, those things directly impact your health. So one of the key areas is policy around how do we make homes truly more affordable? How do we increase access to those homes? Sometimes when people, apply for to rent, sometimes the criteria in order to get into a rented facility, or a rented home, is just beyond the scope of somebody being able to access. So from as a health department perspective, what is our role in increasing access to affordable housing? St. Louis County itself actually rolled out their comprehensive 2050 plan, and one of the key components on there is affordable housing, and that comes directly from the health department advocacy around health and economic mobility. So that's one thing I'm really proud of, and it's new for the health department as well as new for St. Louis County. Other things that we're doing as a health department, Derrick will speak to our clinical care access points. But for us, what we're doing for the behavioral health and substance use, what we do know, yes, opioid deaths are declining, but we still have, the reality is people still use drugs. It's a reality. And so how can we work to engage communities who experience substance use disorders in addition to mental health? How can we truly meet them where they are, correct? So one thing that the health department has done, we've placed vending machines all throughout St. Louis County. We have some pretty high-tech vending machines, and that we have those located inside of the health department, Big Clayton. In there, we actually have hygiene kits available, and so someone can go up for free. They hit the button, they can get soap, toothbrush, toothpaste, washcloth, in addition to Narcan, because we make sure we want to keep access to naloxone available. There's also sexual hygiene and stuff available as well. So we have condoms. We wanted to make those things low barrier access, so where you can just walk in a building, hit the button on the vending machine, and walk back out. Some people may not want to interact with staff. That's at our John C. Murphy location as well. And we plan to roll out more of those vending machines throughout St. Louis County, and using data to drive our decision on where we're going to place these machines at. But naloxone, we have 27 naloxone machines placed throughout the county with a plan to get 41. And then we have 2 high-tech machines that also include the hygiene products in those as well. Additionally, we do have outreach partners and outreach workers who's working with various substance use groups to connect people directly to our clinics. One of the other things that we're doing for our jail, at the county jail, that is an opportunity as a health department for us to intervene. So at county jail, the health department, we oversee all of the medical services there. So anyone that comes to the jail right at intake, whether they go up to general population or not, they are seen by a nurse. We've actually put a provider down there 3 days a week. So depending on which day they come in, they're also seen by one of our providers. We're currently putting in place a new pilot protocol in which we can start people on treatment who are released from intake and connect them to one of our clinical partners. Historically, people were seen, they get discharged from intake, they'll see one of the nurses, we can at least refill medications, but now we're going to take it a step further and also do detailed assessments for substance use and mental health, and make sure individuals are connected to community partners right down at intake. So it's a missed opportunity. And what we were seeing, we were actually missing about 46% of the people who had some type of interaction with the county jail system. So whether it's connecting to our clinics, connecting to our partners or other partners, I'm really excited that we're going to now be able to use that type of facility, a jail, as a place to continue to connect people who don't even make it upstairs to general population. So that will be rolling out within the next few weeks. If someone did get admitted to general population at the jail, we have a mental health housing unit down there that's been there for about a year and a half. And we also have a substance use unit there as well. So individuals get therapy. We have group therapy sessions taking place. We've introduced music therapy. The other thing I'm trying to introduce, everybody know I've been in the news for animals, but I'm trying to also create a foster program at the jail, because there is research to support the individuals who are residents of incarcerated facilities. You can use animals as a way to build emotional intelligence, reduce recidivism. So that's another unique partnership that we're trying to put in place, hopefully before the end of the year. So I say all of that I think, as a health department, although we may not be boots on the ground, we're definitely working with the partners who are boots on the ground, on making sure those who interact with the health department, whether it's our clinical side or non-clinical side, get connected to resources and the services that they need. So with that, I think I wasn't too long. I will turn it over to Derrick to talk about our FQHC. We're so excited about that. And I'll make one minute, because I mentioned the policy part. And local politics. I brought this up last year, and I really think it's important for all of us in this room to pay attention to local government politics. Last year, Derrick, I have to call on, and DivlNe from the Integrated Health Network, and even some of our hospital partners. The county council was actually going to defund all 3 of our health centers in St. Louis County, knowing that we are the safety net. And it took a massive community effort for our partners to reach out to our council members, begging them not to defund our clinics, because we do serve the most vulnerable in the county. We are that safety net. And if you remove the clinical care access at the Department of Public Health, it will literally devastate all parts of St. Louis County. And I say all of that because if it was not that advocacy, the county council would have removed funding from our health department to continue to maintain our clinics. I don't even know if that message got out there, but on the back end, we were both contacting partners. Number 2, the budget cuts that just went through. Honestly, they've cut STI testing. They've cut testing. I mean, and our STI clinic is free for anybody who come and utilize it. I'm using these examples because right now we're currently working through the devastation behind the cuts. And I think if we would have had more of a community advocacy, community voice, and people speaking out, look, these services are needed for the most vulnerable in St. Louis County. So we can talk more about that if somebody have a question, but last year was truly a reality check that the power of politics and how that play in people's lives. And it takes community grassroots organizations, communities to come together to hold our elected officials accountable, because they don't want to, they're not going to come out in the streets with us. So we can talk more about that, but definitely I always want to advocate, please, please, please pay attention to local politics, because we need our elected officials to not pass policies that will cause harm and damage because they are unaware.
Thank you, Kannika. Derrick.
I always preference when I get up and talk behind Dr. Cunningham is to always put me first. It's because coming behind her as a dynamic person and speaker and a tenacious leader is very, very hard to do. So I want to thank you for always the advocacy that you do, and keeping patients first and always keeping community. And I wrote a speech today and I had some bullet points. I always do this. I get up here and I pivot and start talking about something else. But really, the panel before me really moved me, and it reminded me the reason that I'm in healthcare, and it's to take care of the community. And oftentimes we forget that. So that was a great reminder of what we're here to do and why we're here to do it. And then also one of the things that Shantae said when she sat up there is to focus on the people. And it's very, very simple. It's to keep people first. And it's also echoing what Dr. Cunningham said as it relates to being humane and watching over and taking care of patients that really need our services the most. And for me, that's the reason why I chose this role in healthcare. That's the reason why I'm here today and obviously accepted that role. So again, thank you for the reminder. Thank you for being here. Thank you, you all, for showing up and being able to add value to these type of conversations. So I will just piggyback off of what Dr. Cunningham said. Recently, since the last time we spoke or the last year I was here, we have received our designation to become a FQHC lookalike. I'm extremely proud about that. In addition to us being the only government entity in the state of Missouri that holds this type of designation. The reason why this is important is because the health department, since its tenure, has always taken care of individuals from low income, inability to pay, the vulnerable population, the unhoused, and so on. But this will be able to give us a bigger scope, a broader reach, to be able to reach communities that never been reached before, not just for North County, not just for St. Louis County, but to be honest with you, partner with people across the region, the state, and also the country to make this region better in the things that we do. So that's a big achievement for us. It took over 20 years to be able to bring that type of HRSA guidelines to a federal government entity. And I'm so proud to stand up here today and say we've reached that designation and be able to partner with someone like Dr. Cunningham and St. Louis County Public Health Department. So with that being said, again, just to give you all a snippet of what we do, we specialize in treating the most vulnerable populations. That's the unhoused, the Medicaid, the Medicare, uninsured population. We specialize in primary care services, OBGYN, multiple specialty services. Dental for us is considered primary care. We offer dental services, women's health, STI, WIC, Title 10, you name it. We cover the majority of the body of the human being, in addition to behavioral health services. One of the most things that I'm proud about is our outreach efforts. We talked a little bit about that today in the other panels, but how we have managed to streamline our primary care and our behavioral health integration services. So a lot of patients come to us with dual needs from a primary care standpoint, but we are a one-stop shop for behavioral health as well. So we offer everything from psychiatric services, case management, licensed social workers, the et cetera, et cetera. So to have a one-stop shop for a patient that comes in is extremely valuable for us. We recognize that patients come from all different type of walks of life, and they need different types of things when we get there. And we pride ourselves, again, of being the person or the physician group to be able to give the patients what they need while they're there. Another good, from an operational standpoint, we offer easy registration. We do a good job of being able to collect demographics on patients for different reasons, for tracking, to be able to follow up. But the reality of it is everyone doesn't have an address. Everybody doesn't have an ID. Everybody don't have an insurance card. So how as a system can we get better to be able to treat patients, track patients, and not be able to let that be a barrier to access healthcare? We found multiple ways to do it, and we are continuing to get better. But we also understand that those are triggers for patients, and those are triggers for our operations from our outreach team. So one thing that we do well is that when we see patients that don't have addresses or don't have insurance cards, we start asking the right questions. What can we do to get you enrolled into Medicaid? What can we do to get you qualified services? How can we get you connected with local food banks, addresses? With the unhoused, we continue to try to do a better job of reaching out to their community, to making sure that they are fed, and making sure that we can put them the resources so they can continue to live normal lives. And for the topic of this conference or this symposium is meeting people where they are. We also provide transportation vouchers for individuals that come in. We use different services like telehealth to be able to reach individuals. And I will say this from a room of opportunity, everyone that in here that works from healthcare or in the ambulatory or hospital setting, I will say for the most part, everyone does everything great from when patients come to see you. What I think the opportunity is going in and identifying patients that can't come into the system, meeting people where they are. People a lot of times want to go to the doctor, but a lot of patients are prioritizing physician visits with food, with their last meal or their last $5 in their pocket for a bus ticket. So how can we acknowledge and be able to reach out to people in the community that need our help, need our support, that can't come see us in a traditional way? And I think that's the next step for St. Louis County Health Department. And if I'm grateful to come back next year, hopefully I'll have a report out of what we're doing to reach people in those type of communities. And then last, it's a lot of work for everyone to do. We enjoy our partnerships. I want to give a special shout out to the IHN Integrated Health Network. They are very, very big and huge in the community. Just recently, over the past couple months, they assisted and helped the health department feed over 1,000 individuals with free meals. That's big. I thought y'all was going to clap. Yes. We gave out over 1,000 meals in our North County locations at JCM as well. So what that means for us, I know it's just a drop in the bucket, but we, during the Thanksgiving time, we allow people to come in and eat. We stepped up during the WIC and the SNAP situation. We all know how devastating that was, not just for St. Louis, but the country as well. And I really, really appreciate the partnerships to be able to do those things like that. So I will leave you all with this. The FQHC work, it's all about community. It's all about what we do and how we give back. For us, it's not mission creep. It's not us coming in and saying, this is my territory, not to get in. But if anyone in this arena would like to talk about different partnerships or how we can do things better, or even where we fail, I think a lot of leaders don't like to talk about that, or even where as an organization, how not so much we failed in the health department, but how we are failing the community. I'm open to have those conversations. So thank you.
Thanks. Adam?
Good afternoon, everyone. I am very, very fortunate in that I get to be in the same space as many of the people that I look up to every day who are doing some fantastic work in the community. Of course, this panel, but also all of you who in various capacities serve the unhoused population as administrators, outreachers, folks who offer housing. All of us are doing some really great work. We're saving lives. So I applaud you all for being here. So as was mentioned, I am the director of the St. Louis City Department of Human Services. My role this past year has sort of changed shape a little bit. As was mentioned, a lot of my work this past year has also overlapped in the recovery office and the office of the mayor. And so outside of the duties of being DHS director, I'm also working, I think, another full-time job in working with folks on the north side, helping to create programs, fund programs, track programs that get people back on their feet after the tornado. So before I get into that, I think just to set the stage, when we spoke last year, when I served on the panel, I'm not 100% certain what the date was, but I think it was before the point in time count that the city had. And so just a little bit of context for you as we enter into this discussion. The 2025 point in time count that we just, well, not that we just had, but that we had last January saw the greatest modern increase in unsheltered individuals in St. Louis City. Lots of reasons for this, but what we will say is that this is not endemic to St. Louis. This is reflective of a trend that we're seeing nationwide, 18% increase in homelessness nationwide. And we also saw it here in St. Louis. And so the last point in time count in 2024 had around 157 individuals who were unsheltered on a January night. This past January 2025, it was 387. Market increase. This was after we spun up a lot of different shelters to bring those individuals inside for some of the coldest nights that we had. So massive increase in the number of unsheltered individuals in the community. So that's one thing. Secondly, we are seeing this shift in federal strategy when it comes to permanent supportive housing. I'm going to put on my diplomatic hat when I say this and say that presently we have an executive branch that does not value the unhoused community as much as other administrations. And I think that that is a fair and subjective thing or objective thing to say. And looking at what their funding priorities are, it's just a fact. And so we're operating against this federal landscape where we don't have as much support as we did previously, legislation-wise, funding-wise, and we are still fighting every single day to ensure that there aren't substantial cuts in the HUD budgets and in the SAMHSA budgets and other budgets that affect the unhoused population. Thirdly, the tornado. So the May 16th tornado was an EF3. For those of you who do not know, EF3 is a very strong tornado, went through the north side of the city, a part of the city that was already economically and politically devastated for many years. It touched down, sort of carved a pathway that went from Forest Park on up through northeast St. Louis. 20,000 buildings affected, 5,000 households were moderately damaged, 500 households were major damaged or destroyed, 40,000 individuals affected. And this does not include all of the unhoused individuals who weren't necessarily paying rent or paying a mortgage in a facility, but maybe had an encampment or were living in an abandoned building in community with their families that also lost their homes. So massive devastation. What the Red Cross data showed us early on is that around 500 households came through the Red Cross systems that we set up for congregate shelter in the months after the tornado. So a number of families. What we've learned from our partnership with the Urban League is that there are around 700 households that were served in the hotel program, what we call the non-congregate shelter programs. And so we have hundreds and hundreds of families that are facing either homelessness or severe housing instability that was going to stretch through the summer, through the fall, and potentially through the winter. And so what we understood soon after the tornado, certainly by the end of the summer, is that we had to act very quickly to understand the scale and scope of the issue, the types of programs that were going to be needed. Number one, looking at the point in time count that we had done this past January and the number of individuals who were displaced, we're going to need to set up some programs pretty quickly. And so part of my function in the mayor's office and in the Department of Human Services was to think through what sort of programs and opportunities we can put in place to serve some of these households that were affected. I think a lot of my role this past year hasn't necessarily been thinking all about health, but more so about stability. But as we understand the linkages between health and stability, they're, part and parcel to the same thing, right? Housing is one of these social determinants of health. If you don't have housing, you lack consistent healthcare and a consistent foundation by which you can live your life and stay healthy. And so one of the things that we thought about over the summer in terms of health is cooling options for individuals who are unhoused and who are unsheltered. And so worked very closely with the health commissioner, Victoria and Worry in the health department to set up different cooling centers and cooling stations around the city, including some at encampments. And then working with the different cooling centers around the community to make sure that they had hours that were open and advertised and amenable for the public. In the fall, the conversation changed a little bit just because we understood that for the winter, we were going to need some more drastic interventions to make sure that people didn't freeze outside when the weather was frigid. And so we worked very closely with the mayor's office, board of aldermen, comptroller, budget division in the city government to free up some additional dollars that could go towards hotel programs, shelter programs for those who were experiencing housing instability. And so for us, this has been a journey wherein we have found that the immediate solutions for folks were stability, but also the longer term, medium term solutions were working with organizations in the community that could offer health services or other ancillary services to support people, such as medication services, mental health services, outreach services, things like that. So I think what we're working on right now definitely follows in that track, and that if you're not aware, we've activated what's called the Code Blue Protocol. And so the mayor signed an executive order 93 that gives me, the director of human services, the power to designate Code Blue for the city whenever the temperature drops below a certain threshold. And as part of this work, we have partnered with a number of different shelter providers in the community, the continuum of care, to activate a number of beds above the baseline number of beds that we already fund to make sure that people have an opportunity to come inside, get inside when it's cold out, so that they can prevent frostbite, hypothermia, et cetera. We're also very fortunate in that partnership to have a strong relationship with Bi-State, who is able to provide us some shuttles and transportation assistance for various rally points around the city. And so we want to make it as convenient as possible within the resources that we have to pick people up in the community, take them to shelter, give them food, allow them an opportunity to come inside and get some of the help that they need. So in terms of what DHS is doing and what we will continue to do, it's going to be to support the providers who are in the community who are already doing this life-saving work, and to make sure that we're working across city government with the building division, mayor's office, recovery office, comptroller's office, all of these folks, board of aldermen, to pass legislation that expands funding and resources so that we can pay folks to go outside and do the work needed to save as many lives as possible. Thank you.
Yeah. Thank you, Adam. Dr. Nolan?
Thank you, Farrin and Mercy Hospital, for hosting this for the second time. I don't know about you all. I thought this morning was a phenomenal program. I love the opportunity to get to hear from Jim and Brett every time that I hear them speaking. I try to go. It's also heartening, I think, to look around the room and see so many people who are showing up with an interest in this work. And I want to talk to you a little bit about what we as street medicine have kind of accomplished in the last year. I want to start in a very different place, though. I think it's important to acknowledge that in the last year, since we were here last, 11 of our patients died on the street, in their tents. Some from the cold, at least one from congestive heart failure, some from violence, some from mental health concerns. I think we have to start there, because while there are a lot of statistics that people talk about, and statistics are important, this is something that is very palpable for us. These are people that are our friends and family, as you saw earlier. These are people that I actually have a lot of joy seeing every week. And so every time someone passes away, that feels like a failure to us. And so if you would, just maybe we can take a second of silence for those that we lost in this last year. Thank you all for doing that with me. So in the last year, we have been blessed with a lot of generosity, both in donated time and in money. You've heard a little bit of the story of how this started, and it was a solo endeavor. And slowly, I just met people along the way that said, "That sounds kind of interesting what you're doing. Can I join too?" And I never thought that I would find so many people that were as crazy as I am to start coming out. But I just want to say in 2025, we had more than 100 individuals who volunteered, contributing more than 2,600 hours of time. These are physicians, nurses, people that otherwise have day jobs. So they're taking time from their families, their nights and weekends to do this work. And the reason that I want to acknowledge that is I think there is an appetite in St. Louis for the community serving the community, right? We have so much ability. We have some of the greatest healthcare systems here, and yet in front of us is so much tragedy. And so I'm heartened to know that there are people that are helping now, and there are people that are here today that are just now hearing this message and that are going to be helpers in the future. I think that's such an important message, especially in a time where all we hear is negative, negative, negative. We continue to have a waiting list of volunteers that we're trying to go to work our way through, and we're just really grateful for everyone that takes the time to come out with us. For me, the first and foremost, I love seeing my patients and the people that become kind of our chosen family. And the second best thing is just meeting the other kooky people that come out with me on the weekends to take care of the homeless. We also continue to find support financially through a mix of grants and private donations. Mercy has donated to us, Edward Jones has donated to us, the Wool Foundation, and others. And we have been bolstered by a mix of formal and kind of informal partnerships. We've worked with organizations like St. Patrick's Center and Places for People to try to really, to the best of our ability, provide some wraparound services. If you do this work for any length of time, you realize that it takes a village to take care of one individual, right? These are people that have multiple appointments they need to get to. They may need help getting IDs, getting back on social services. And so now more than ever, as resources dry up, we have to create collaborations and connections. And so far, that's all been informal, where Sarah can call me, or someone from another organization could call, or I can call them. But I think we have to really think about how do we share and pool resources, especially as we enter a really austere funding environment. To this end, I want to announce for the first time here that StreetMed is forming a partnership with St. Louis University. And so we're actually, I'm going to work there part-time and help develop their mobile medical outreach program. They're investing resources and time into that. We will remain an independent entity, an independent 501c3, so we can continue to be facile and work with Mercy, work with WashU, work with other institutions. But this is a really important investment into this space by a large university that I think recognizes the need. So I would like to also say that part of this, the intention of this, is also how do we develop that pipeline, not only for StreetMed providers, but for people that can be compassionate and understand and be responsive to those of us that have otherwise been ostracized from the traditional healthcare system. And so implicit in this partnership is us finding pathways to help train medical students, residents, and other trainees in trauma-informed care, and how to be more sensitive to the needs of those who, again, otherwise are marginalized. I would also say that, we've had a lot of successes. There's also been, a lot of challenges this year. The landscape around street work continues to be complicated by shifting priorities, both locally and federally. There have been a lot of changes in the last year in funding, reimbursement, and that's really complicated the sustainability of this work. We've heard a little bit from other speakers about changes in how the federal government funds these services. You've heard about the One Big Beautiful Bill. If you're in this space, you may have had whiplash this last week because the federal government announced they were going to cut $2 billion in funding, and then 24 hours later, maybe not. And a lot of us still don't know where this is going to end up. I can say that many that we've applied for grants that have been in limbo for months and months and months. And that makes it really hard to try to grow and scale when you really have no idea what their funding streams are going to look like. I think that the other thing we have to recognize is that these shifts in priorities and the rhetoric that we're seeing on TV is part of a broader national trend, which is some fatigue around caring for the homeless, or at least homelessness in general. And while I think that, obviously I might have a different opinion than people that are feeling that fatigue, I think we have to recognize that this is something that people are really feeling, that people don't want to see the number of homeless people in their communities. And unfortunately, there's been increased criminalization, punishment of homelessness under the guise of things like public safety. And this has really increased dehumanization of this population. And once you start to dehumanize a population, then society starts pushing further and further and further into taking rights away. The sweeps of homeless camps that we've heard about, deprioritizing harm reduction, which is now kind of a bad word, I guess. Decreased access to social services, such as Medicaid, SNAP benefits, have really threatened the progress that we as a society have otherwise been making. To be clear, I think homelessness is a very complicated issue. But when you get down to the root of it, regardless of any one individual, the issue is lack of affordable housing. There is really no other, if you look study after study after study, there's no thread that binds in any way than a lack of affordable housing. So I think, I'm proud to say that despite these challenges and despite some of this rhetoric that you hear nationally, that we are proud to continue doing this work. Last year, I stomped on the ground and yelled about having a EMR, and we ended up getting our own EMR this year, which is a great thing. We continue to deliver the care that we think is the best possible care that we can. We've made partnerships with West Pine Pharmacy and the Washington University Infectious Disease Clinic. So now, not only are we the main prescribers of medications for substance use for folks, we are prescribing them and delivering them at the point of service. So these people are, thank you. Yeah. And, I like to use this analogy, which is that, for many folks that are living in this situation, that are unhoused, it's kind of like people are out, drowning, and you're saying, here's how to swim, just kick your feet, right? That's not what they need right now, right? They need to be pulled to shore. They need some stability. And then you can start to teach them how to swim and prevent this from happening again. But I think we're getting a little inverse in how we're seeing these things and making people get into to treatment before housing and things like that. We have to deliver some level of stability. And so we as an organization are trying to do that. We're trying to throw out the life preserver, see if we can pull people a little bit back to shore, help them help themselves, as KT was saying earlier, and then provide them with opportunities to build from there. I would like to say, at least in the last 6 months since we've had our EMR, we've helped more than 320 unique patients for more than 550 episodes of care. And so that means that's an actual clinical visit where someone had medications prescribed or had some medical intervention. We certainly see these folks on a weekly basis for most of them, and create this longitudinal relationship that really helps us to create kind of a bi-directional relationship for us to be better and to help them be better. I would say, despite all this, the need greatly outpaces our current infrastructure. For as many places as we go, there are dozens of places that we're not going. There are places that we wish we could go. Our funding remains somewhat tenuous. At this time, we're still using all of our personal vehicles. I'm on my 3rd flat tire. We are relying mostly on donated supplies and medications. I would say our volunteers, half the food we give out is actually just bought every week by our volunteers who bring it with them. And add to this the climate in St. Louis and in Missouri more broadly around social services and the lack thereof. And it can be difficult and sometimes demoralizing to do this work. But I would say that we remain unfazed because I think this is too important to give up. This is something that, it's hard to count the successes, but there are little wins along the way. And we just have a saying in Street Med that a little bit of love can go a long way. And regardless of what our funding looks like or what we have and what the world looks like around us, we plan to keep showing up, even if all we have to offer is a little bit of that love. So.
Thank you, Dr. Nolan. Dr. Scoggins, Yusef Scoggins was on the panel list, and we thought that he was not going to be able to make it, but somehow he juggled his schedule and he actually came, which we really appreciate, Yusef. Just a little intro. Dr. Scoggins was actually here last year as well. He's the executive director of the Delmar Divine Charitable Foundation, which is focused on innovation, collaboration, and transformation of communities north of Delmar Street. He's been an amazing champion for a lot of things that you've heard throughout the symposium. And I'm really, really fortunate to have him come today and give us an overview of what he's been up to and maybe share with us some wisdom. Thank you again, Yusef.
Good afternoon, everyone. Happy to be here. Sorry to be tardy to the party. And to my panelists, I appreciate you all and seeing you all again here this year. What a year. Does everyone agree? What a year. I won't go into rehashing a lot of, I think, important components and topics that were mentioned here and some of which I did not hear, but I will share a few things that have happened over the last year or so since we were meeting. Over this last year, certainly there's been a lot of hardship, but there's also some bright spots. So at the Delmar Divine, we are looking next month to close on the second phase of our project, which will bring online additional affordable housing. So that'll be 81 new, fresh, centrally located, accessible units of affordable housing, which I think is a key aspect. We were right in the middle of the tornado zone. We're just a few blocks from Forest Park on Delmar near Union, and most of the buildings across the street from us were severely damaged, and many hundreds of individuals were displaced as a result. Our building suffered about $2 million worth of damage as well. And by the grace of God, we were able to get some things back online in short order and still be a service and allow the nonprofits in our building to provide services. That's inclusive of outreach, behavioral health needs, et cetera, in response to the tornado. And so I think that's a bright spot, right? I also represent the St. Louis County Continuum of Care, and I've been the chair of the St. Louis County Continuum of Care for the last several years. And within that context, we have noticed a number of things. Everyone, how many folks in the audience live in St. Louis County? All right, the majority, as the majority of the population lives in St. Louis County. And what we also know is for all of the folks who are St. Louis County residents or not, how many folks have said or heard that we have a budget issue in St. Louis County? Yeah. Now, I put that in the context of what was already minimal funding from St. Louis County when it comes to homeless services. And so we're in constant conversation with the Department of Human Services around advocacy for additional funding for homeless services. We, just for order of context, we have about $2 million of money that primarily comes from the federal government to support the unhoused in St. Louis County. And you know that's a large, vast geography. And the organizations that are at the table supporting us in this work are really efficient and effective, but at some point you need resources to do things at scale. And one of the major gaps in St. Louis County is that we don't have an ongoing 24-hour shelter for men, single men, right? And she's not clapping because that's a good thing, right? She's clapping because somebody has to speak it, right? Someone has to talk about some of the gaps that exist. And our nonprofits are doing, I think, really a yeoman's job of trying to cover for some of those dynamics, but that's a challenge. And I'll dovetail that with the point in time count. So Dr. Pearson spoke about the point in time count nationally and also in the city of St. Louis. You'd be kind of surprised to hear these numbers. In St. Louis County, our point in time count last year, 2025, comparable, is actually a 9% decrease in overall homelessness in the point in time count, and 36% decrease in the unsheltered count. How many people believe that? She doesn't believe it, right? I would say this. I think there's a lot of work that's happening, and I only bring those statistics up because statistics don't always tell the full story. The full story is that we have people who go for services wherever they exist. And if a service does not exist in your area, you're going wherever you can seek that refuge. And so if we don't have an all-male shelter in St. Louis County 24/7, then where are all the males going? And this is not a blame game. This is not a regional fight or sort of potshot politics, right? This is just honesty, right? And so what I hope for in 2026 is a more regional effort around some of these matters. Real collaboration, real support of one another, honesty about the gaps that exist, because without that, St. Louis is cooked. Missouri is cooked. As has been shared before, we have local, federal, local, state, and federal. Let's not skip over state. Local, state, and federal that don't always have an understanding at a minimum, or maybe even the interests of those who we're talking about today. So I just wanted to cover that in some part. One of the other bright spots for St. Louis County over this last year, which could have contributed to some degree the decrease in the numbers that I spoke to whatever degree they're 100% accurate, is that Loaves and Fishes, which is a longstanding nonprofit organization operating out of Maryland Heights, did open up an additional drop-in outreach center in the mid-county area. And that work, I think, is extremely important because those sort of drop-in center and outreach efforts help to divert individuals who might otherwise fall into homelessness if they didn't get some of that temporary or initial support. So diversion is a key aspect of the work, and that sort of initial connecting with people when they need it is really, really important. Imagine having a hospital without an emergency room, right? By the time they get to you, they're dead, right? If you didn't check them out and do an EKG, do some cardiac enzymes, they're gone, right? And so it's important to meet people when they need some of those services. That's a critical aspect of it as well. So I do believe that effort has been supportive of some of this work, but there's still more to do. And so the continuum of care is continuing to broaden our arms and bring more parties into the fold to support some of these efforts going forward. I'm getting closer to 50, so I'm sometimes losing my thoughts. But I just wanted to share a little bit of those as sort of overview of what's happening here in the region. We have a lot of movement back and forth. While the tornado did hit the city of St. Louis, my neighborhood in particular as well in the city, very, very hard. People often forget that there was a tornado that hit St. Louis County right before that. And it hit North County, right? So I think we need to be more thoughtful about where we're supporting people, where we're delivering services, and utilize that in a way that's going to really be helpful moving forward. So I appreciate your time today, and I look forward to discussing more.
Thank you, Yusef. You have to remind me what I have to look forward to when I turn 50. For those of you who are still awake, sounds kind of funny, but really, really appreciate everyone's update. We got about 5 minutes or so for audience to ask questions of any of the panelists, and maybe there will be a question that will need to be answered by more than one panelist. So please feel free to come up to the microphone and ask your question.
Hi, my name is Flannery. I'm with IFM Community Medicine. I'm familiar with a few of you guys. And we work with the schools, early childhood centers, and shelters to offer primary care services on site. So my question for you guys as leaders in the community and I think all of you have touched on this, I'd love to hear a little bit more about some of the challenges that you face or you see community members face when accessing and affording healthcare. Thank you.
Okay, you want to start with that? Or does that work? Does it turn green?
Ready?
Yep.
Yeah. I think the biggest part for us is to, as leaders, as we continue to stay in this space and keeping community first and community and keeping patients first, is being able to manage and being able to keep our doors open to be able to give away good, affordable healthcare to people for free or at a low cost or at a sliding fee discount payable scale. So for those who don't understand the FQHC model, that's why it's very important for us to get our designation, is because we can then get funding, get higher reimbursement rates for Medicaid. We can get higher reimbursement rates for Medicare. And then we can do things for the self-insured or the self-pay that we could never do before. And that's give away high quality healthcare. So as we are always in the space of keeping community first, we would like to continue to take advantage of programs that would allow us via grants, via, philanthropy given, whatever that looks like for us to be able to continue to move forward into that space. So that's why it's very, very important for advocacy. Especially in what Dr. Cunningham and I do, we're in the realms from where constituencies and from where people matter in terms of where they put their tax dollars, and we want to continue to prioritize healthcare because, again, for places like us, people can come to us for free, sliding fee scale discount if they don't have money. We don't give low tier care based on your ability to pay, and and a lot of times we very rarely even go the extra mile of being able to check these different types of mechanisms that people can pay. So the beauty of it is for us to continue to stay in those spaces and take advantage of these different type of designations that we get.
I'll just add one thing on there. I think one of the challenges from the organizational perspective, and I think a few of us touched on it, was coming down from the federal level. The grant funding is drying up, but I will also say for us as a health department, the updated terms and conditions that have come down to us have caused us to forego some grants that we've had. One of the things in the terms and conditions is that we have to allow ICE the ability to enter our clinics whenever they want to. Number two, we had to they were requesting for us to remove any language that referenced DEI on any of our county websites. The decision of the county executive was not to comply with the federal government, which I do respect that. And I do think that seeing patients in the clinic should be something that's private and protected. No patient should come to our health department and feel like ICE can come in at any given time. So we have lost some grants because we could not agree to the new terms and conditions. And that's something that people didn't even know about that happened. So as a result, we have lost quite a few grants because of the updated terms and conditions with these federal grants.
Mm-hmm. Hi, Dr. Jim Withers from the Street Medicine Institute. I'm not sure I have a really specific question. I just wanted to make an observation that I'm just a simple street doc, so I don't know that much about how the government actually works. But I've seen maybe the emergence of local initiative to fill gaps that aren't the way traditionally we see things. And, I've never heard of, maybe there are other counties that became FQHCs. That really blows my mind. In Morgantown, West Virginia, the Department of Public Health runs their street medicine program. And there's a number of other examples I can think of where entities are embracing things beyond what I typically would have thought. Again, too much of a question, but I'm wondering if you guys have thoughts about where street medicine in the future might fit in. I always felt that it's kind of like a fire department. Everyone should have one. Do you guys have thoughts on that? I think there's value in keeping independence from governmental structures, but gosh, we're still waiting for the cavalry to come and make this sustainable. Thanks.
Dr. Nolan, you want to take on that?
Yeah.
Yeah, I can chat about that. It's almost like Jim was a plant in the audience. Huh? I think to answer that question, I want to go back to the previous question that Flanagan asked. And I think we all heard the question and maybe we all interpreted it in different ways. And one of the things I think what I heard, or at least the lens that I looked at it through, were what are the barriers of patients making it to many of these opportunities for care that we're presenting, whether that's the multiple FQHCs, the county, pro bono clinics. And I find that there is, as Brett pointed out, a segment of individuals that are, for whatever purposes, just unable to participate in those things that we've built, right? So we can build the JFK clinic at Mercy, but you're going to have a percentage of the population that's never going to be able to make it there, whether by proximity, whether it's by resources, or maybe they can, and it's how they are treated or how they feel when they walk in. I'll give you a great example. We really moved mountains to try to get this patient of ours who had a very painful hernia into a clinic. And we tried to get him into surgery, and surgery wouldn't seem till he had a primary care, and they wouldn't count us as a primary care. So then we moved all these things to get him into primary care. We got him a primary care visit. I won't name the hospital system. We did all of this work. We went and picked him. Like, we had to like make sure he was going to be at the place that we could pick him up on the day of his appointment. We get him there, and a front desk person said, "We don't take his insurance." And it turns out that front desk person was incorrect, but we did everything right and got him there at the right time, the place he was supposed to be, and he got turned away. And now, like Sisyphus, that boulder has rolled right back down the hill, right? And every time that happens, you erode a little bit of trust with that individual, and you lose them. They're again, if I go back to my, throwing out the buoy to save someone, every time those things happen, the rope gets a little farther from shore, right? They're less likely to trust and allow you to pull them back in. And so I think that's the role that street medicine is meant to play. Is this should be a continuum. It's not this or that. It is, there is a lot of options for people to enter at the point that they're ready to enter. If that point is, I'm ready to go into a treatment program, I hope that we have programs for that. If it's permanent supportive housing, I hope we have programs for that. If it's, I'm not ready to leave my tent yet, but I'm kind of thinking about it, then there's street medicine for that. How do we have conversations around that? And I don't know if I'm answering your question, but I'll go on one small little tangent, which is, as I've gotten to know as many folks as I have, one size does not fit all, right? In as much as we need programs that cater to different people, your approach has to cater to different people. You as a physician, you would not suspect that as a neurologist that you could treat all neurology patients the same, right? And so for some people, we can't start on their hypertension until we get them a little more organized in their mental health. We can't start on their substance use until maybe we can convince them that there's some self-efficacy in taking a medication every day. So there are different places you have to start. And I think street medicine is, as Jim O'Connell says, intentionally inefficient healthcare. It is meant to be resource intensive, not to care about what the throughput is, not to care about what the ROI is. It's meant to be humanitarian and say, can I shepherd this person a little bit closer to the traditional healthcare system and help maybe hold their hand as they walk through the door? And I think that's the role it should play. And I think we should be fine with, throwing some money away to help people because it's the right thing to do. Now, the bean counters don't like that, but it does pay dividends on the back end, because there are people that are not ending up in the hospital with catastrophic endocarditis or ending up in the hospital with amputations. So the problem is, so I got off on a meandering tangent, but so I'll pause there.
I want to add something, because you made a great point, and I don't know if I glazed over it during my presentation earlier, but that's why it's very important to where this next phase of healthcare, we start meeting people where they are, right? And again, I'll say it. We do go ahead and clap. It's fine. All systems across the country. I've seen a lot. I've worked at a few, but all systems in 2026 does a good job of treating patients when they come to our front doors, right? We have to do a better job of finding the patient that can't have those, that don't have that access, that don't have those means of transportation, that don't have, maybe have the money to prioritize healthcare, but they also have kids or family members or loved ones, and they're making the decision whether I spend money on food or do I spend it on a copay, right? We have to reach out and help those people as well as the fortunate, the privileged, that, or the highly resourced, that be able to come in and get that and get those different types of services. Another big thing from an operational standpoint, believe it or not, is wayfinding. People won't go to the doctor if it's not parking, right? If it's hard to get there, they like, I don't want to go there. I can never find a parking spot. All of these things matter when it comes to patients. And one thing I will say that I do agree with the federal government when it comes to the FQHC and HRSA requirements is that any patient, so we accept patients due to inability to care, and we treat the most vulnerable, but we only do primary care in some specialty, but any patient that qualifies for anything further, systems or processes or services that we don't offer, we have to make sure that we partner with an organization so that if you come to us at $0, when we refer you to that surgery, guess what? It's free or $0 or something close to it, something that you can afford to continue your care because it don't stop in our doors. So I will say that a lot of partnerships and a lot of hospitals in this region, we do have partnerships with. They take charity care. They have programs, sliding fee discount programs as well. And so I said that in addition to the statements that you made, but also to advocate for our patients in the community that if you know people, don't let an insurance card or lack of money stop individuals from coming to the doctor.
Dr. Koss, you want to ask a question?
Well, I have a question. I'm not sure exactly that maybe our panelists are the right people the more I think about it, but I think it's a relevant question because the topic of the discussion for this afternoon is housing and healthcare. And I think our speakers this morning pointed out that I think it was maybe San Diego and San Francisco, I'm not sure, large percentage of patients who go to the emergency room are unhoused patients. There was some number about 75% mentioned, I think. And I think, yeah, Doctor, I think you just mentioned that actually for very complicated cases and situations, patients have to go to the hospital. So my question really is this, given that we have all recognized and we agree that housing is really important because really the pictures that we saw are just absolutely heartbreaking. Discharging patients from the hospital and sending them basically out on the street with a catheter that's hanging out of the drain, or I mean, just unconscionable, really. So is there some sort of a discussion, could you reach out to hospital systems and administrators? I see maybe a few of them here. I don't know whether there is any partnership that could be done so that actually the hospital systems invest into affordable housing and there is some sort of a collaborative effort that is developed. Cleveland Clinic has done that. I read about it. So there is actually an effort that Cleveland Clinic has recognized that there is an important problem in the community with housing. So wouldn't that be maybe some resource, or maybe it's been already explored? I don't know. Maybe you know about it. I'm not familiar about it.
Sure, I can take this one. I think this is a phenomenal transition to a discussion about hospital for housing. How many of you have heard of that program before? So I see a few people in the room who either administer that program or are deeply familiar with it. And so essentially what it is, thank you, doctor, for the question. What hospitals have come to recognize is that it is very expensive to keep treating people in emergency departments, especially if one of the reasons that they're there is because they do not have housing. A very quick 30-second personal story. I used to work at an organization where I oversaw housing development for individuals who were long-term unhoused. And so one of the reasons that one of our guys went to the emergency department every single week, he complained of chest pain. He may or may not have actually had chest pain, but one of the things we knew for sure is he would go to the emergency room so that he could do his laundry. So he would go and say, I have chest pain, but also I have this bag with me if the nursing staff could help take care of it. And so they would do some of the diagnostics and work with him, and they would treat him because they were compassionate healthcare providers. But he saw the emergency room as a pathway to accomplish some of his activities of daily living. Not going to argue with the guy. I mean, if you got to pay $10 at the laundromat to wash all your stuff versus calling an ambulance, getting a free ride to the hospital, having the hospital do your laundry, they discharge you the next day, you got clean drawers, you are good to go, right? So I think for a lot of individuals, they go to the emergency department for a lot of different reasons. some of them psychiatric reasons, some of them very, very legitimate healthcare or emergent care issues. But the hospital to housing program is a program that provides housing, long-term housing for individuals who are frequent users of emergency departments. And I think, you know, we could have a whole different discussion on the data from that program, but the outcomes are the individuals who were placed in housing from those programs had dramatically decreased Medicaid costs, dramatically decreased number of hospital visits, just because their needs were taken care of at home. And so I think the argument for these types of programs is that it's safe for the bean counters that you reference. It saves people money, it saves the system money, saves the hospitals money. The staff don't have to worry as much about folks coming in who just want to do their laundry or get a cup of coffee or come inside out of the cold. And they can focus treatment on the people who need it most. So yeah, hospital to housing is a great program. I encourage you all to look it up. St. Patrick's Center, do you all still, you'll see St. Patrick's Center has a hospital to housing program that has some great results. So encourage you to look out for that.
I just want to say my feel to that. I think hospital housing programs are wonderful. I think they serve a purpose. I think we have to be careful with who is providing housing and whose needs we are meeting. So if you were here last year, a really great researcher from Yale, Caitlin Rayus, demonstrated data where they connected Medicaid data to their homeless management information system. And, you know, there's this perpetuated idea that unhoused people use the ER very frequently. Turns out most ER utilization was by about 2% of their unhoused population. So about 98% weren't really seeking care at all, which is very similar to what Brett was talking about earlier. And so if we only house people or invest in people who are using the ER frequently, we're sub-selecting a portion of the population that may or may not be sicker. Maybe they're just using the ER because they need to do their laundry. Now, I'm not saying we should punish those individuals, but it is a inherently system-focused or healthcare system-focused solution, which is cost of the healthcare system. It is one solution, but I think it is not equitable, right? It doesn't necessarily approach it from the 98% of other people who may be just as deserving of housing, but just don't happen to use the ER where they're paying for people to get housed. So it's a very complicated thing. And I think we have to be very thoughtful when we develop housing programs that who decides who is deserving of getting in these housing programs. And that becomes really hard.
We only got 5 more minutes for this session, maybe time for another 1 or 2 questions if they're really quick. Go ahead, please.
Hi there. My name is Michaela. I'm one of the nurses up on Trauma Surge, and I had the privilege of talking with Jessica. I'm not sure. Oh, she's still here. With Jessica after the panel discussion from earlier, and she was just sharing some great thoughts even after the panel, just about things that she's seen in her experience. And I didn't know if there was a space already, and I just may be unaware. So I'd love the opportunity to be informed here if I am unaware. But if there is a space for where usually people may come into like city council meetings where the public can come, if there's a space for people to come, like those to be out so that people can feel maybe more welcomed in the unhoused community, to be able to share their voice where it doesn't seem like there's maybe this invisible barrier where maybe, I don't know, if maybe they don't feel like they can come in or they don't feel like they'll be welcomed. If that can come out to where they are.
Yeah, I can speak to this. So right now, in St. Louis County, I want to applaud Larry Rice. He has been to the last 11 council meetings advocating on behalf of the unhoused, asking the county council to dedicate funding to help those who are unhoused in St. Louis County and who experience homelessness. Let me tell you what happened with that. Nothing. But they still show up. He also brings people with lived experience. So for the last 11 times, the St. Louis County Council have heard stories from mothers and children, from men, from grandmothers, people who are taking their time to come to these meetings to talk for 3 minutes to share their stories. And I have to applaud them for doing that. And I get that we're in a budget cut, but where's the priorities? Because you're right, it's safe long term. And I want to put this out there too, because they just dropped this on the agenda. This year, they also cut $65,000 from the warming shelter in the middle of the winter in St. Louis County. So when you say that, that says a lot, because our elected officials, they're not listening. They're not coming to me or the human services director who directly have services and programs that serve the unhoused in St. Louis County. It's just dead silence. Now, I do believe they met with him and some of the others, but it's not being prioritized. And it's just being cut. But I agree with what you said. If you cut and we don't prioritize, later on, we're going to find ourselves in a deeper situation in which we're going to see people die. We're going to see people experience more of a housing crisis. And so that is really strong. And I actually think, if anyone knows Larry Rice, I think he should still show up. I think he should still continue to bring people, because for me, they need to know and they need to see and they need to demand for their voices to be heard. So money will be put back in the budget and prioritized for those who are in St. Louis County who are unhoused and who want access to healthcare, who want access to food, clothing. Our St. Louis County Council needs to do that, and they need to listen. And I'm sorry, I get frustrated every time because I'm like, you hear these stories, like, where is your heart? Why are you cutting? And you have two directors that we're trying to meet the need of St. Louis County, but you're not even working with us because of something political. So I think they need to keep showing up. And I think anybody in this room needs to show up and talk about on the healthcare side what this means, because they don't believe us. And I think the more we do that, hopefully we'll see a change.
Thank you.
Yeah, I'll just add a couple comments to that. And I appreciate Dr. Cunningham's comments. And I think about those county council meetings I used to attend years ago. Afton had a miniature golf site that was going to be redeveloped into some subdivision, and those folks showed up in droves. They filled out the entire county council meeting. They kept coming, and then that persuaded. I think one of the challenges with the unhoused population, and this is the case for any sort of marginalized or impoverished population, is how do you have a critical mass and continue to show up when you're struggling just to survive? And a lot of the politicians realize this, and so it sort of waxes and wanes. But I think it's important for all of us in this room to also think about how do we show up for these same people, not just in the hospital, but also outside in these spaces and places where it really matters, because that 65,000 that was cut, that's going to impact the continuum of care for which I represent that supports these individuals. I would also like to mention that while we're talking about those who are literally unhoused now, let's not forget that there weren't unhoused at some point. And there's a slide, there's a progression of folks who are unstable all the way to becoming unhoused. And if you look at the Post-Dispatch or any other publication here locally or nationally, you'll see, and particularly in St. Louis County, a significant number of apartment complexes where people continue to be displaced. Condemnations that happen in mass and nobody bats an eye to it. And where do those people go? No one's asking the questions. Just another key data point, St. Louis County, and this region in particular, St. Louis City as well, has one of the highest per capita eviction rates in the country, right? And so while we are always deemed to have affordable housing relative to some other parts of the country, folks are really just moving around from one place to place. And this also goes to the question that was asked that Dr. Nolan spoke to earlier. Street outreach, I think, is put in a tough spot when you're having to move from place to place all the time, because people are moving from place to place all the time. And so it's also a question of how are we stabilizing community as a whole so that we're not having folks that fall into homelessness in the long term.
Maybe one more minute.
Okay, I will make this quick. My name is Sonia Deal, and I am with Bridge of Hope Ministries, where we are actually we developing and implementing a medical respite location unit for individuals who are unhoused, being discharged from the ED as well as the hospital with no safe place to go. We are that community of hope and healing. So I look forward to speaking with all of you on the panel sometime soon.
Thank you, everyone.